Hello everyone, greetings from India. So first of all, I would like to thank the organizers, especially Dr. Philip, for inviting me here to talk about my favorite topic on sustained low efficiency dialysis in sick children. Over the next few minutes, I'll be discussing with you the research and our work on sustained low efficiency dialysis in children. And I'll start with a representative case, a case of severe dengue. And this child is 20 kg child. He's ventilated, he's fluid overloaded, he needs a lot of PEEP and FiO2, he's overloaded, he's on one inotrope, he needs dialysis. Now we'll be discussing what options of dialysis we can offer to this child in our part of the world. Now on your screen is you can see that this is showing the patients who receive renal replacement therapy, the proportion all over the world. And you can see that in the West, especially, everyone who needs RRT gets it. However, in the less resourced nations, it's not like that. Those who need RRT may not get it because of many financial and resource constraints. There have been studies showing that prosperity relates directly to the access to RRT. So, if you have a country which has a higher GDP, there you will have more prevalent dialysis population because of better availability of resources. So, the problem is that if we compare the resource to the less resourced nations, 80% of the world population in fact lives in the less resourced nations, and these are the people who really need dialysis, especially for a critical illness. Now there are many issues in the less resource world, from lack of information on the preventive measures, lack of access to healthcare. Not everyone is insured, so if a child gets a severe acute kidney injury, it's a out of pocket expense for whole of his family. And they have been increased exposure to communicable disorders including tropical illnesses like malaria, dengue, and so on. So our group, including Dr. Bunchman, Dr. Raina, and me, we looked at what is the modality used in children all across the world, whether it's developing or the developed nation. So what we did is we circulated a survey on many listservs, including the PEDNEF listserv, the PEDCRRT listserv, and we found this. What you can see here is these are the centers who responded, and in fact more than 50 centers from United States responded, and there were multiple centers from the developing world as well. And if you can see closely, you'll find that there were a lot of green dots here, which suggests that in fact children here in this part of the Asia were in fact seen by adult nephrologists also. So not every child who gets a severe AKI in less resourced nations is being managed or being seen by a pediatric nephrologist. So in fact adult nephrologists, general pediatricians are managing these children. So when we asked, out of these 250 responses, do they have a pediatric CRRT availability in their centers? And we found that in the less resourced nations, pediatricians and adult nephrologists were the primary caregivers. And when we asked in India, we found that there were only 4 centers in India who were able to provide CRRT to children less than 10 kg. So there were not a good awareness and training of resource personnel for CRRT. When we asked whether everyone is insured for RRT, we found that children who were in the developing and the less resourced nations, it was an out of pocket expense for all of them. When we asked them what is the choice of modality which people use in unstable pediatric patients, and we found that PD was the most common modality used in the developing world, while in the developed world CRRT was a more common modality used, and only few centers used sustained low efficiency dialysis. When we asked what is the most common modality in older children, again in the developing world PD was the most common modality used in older children. What about infants with AKI? And we found that in infants, again PD was the most common modality used, followed by CRRT in the developed world. So coming to availability of SLED, not many centers had availability of SLED, and there was only one center, which was our center, which was using SLED with convection. Not many centers had availability of pediatric size hemodialysis tubings. So almost 20% of the centers were not even having the typical pediatric sized hemodialysis tubings for these children. So coming back to this child, what modality can we offer to this severe dengue with fluid overload with shock? Now, what are the goals for renal replacement therapy for a critically sick child? What are our goals? Our goals are to achieve good solute and ultrafiltration goals for this child. We need satisfactory patient outcomes. We also need a modality which is accepted well by the nursing personnel as well, especially in COVID-19 when you already have an overworked nurse. She has to take care of the CRRT as well, she has to take care of the child as well. So, we need a modality which should be accepted well by our nursing and the dialysis personnel as well. We need a simple procedure, a low cost, and if possible a nocturnal scheduling. For example, we do have patients who need an investigation at night, a CT scan at night, so we can in fact stop, if possible we just do an intermittent dialysis in these patients in the morning, and we are done with the dialysis for those patients, and we don't need a continuous replacement therapy. PD is good. However, there are many issues with peritoneal dialysis in AKI children. They have erratic solute and fluid clearance, especially in the presence of shock. There's a risk of peritonitis unless we advise a soft tank-off catheter in sick children. CRRT is good, there is no doubt about it. However, CRRT is a specialized machinery which has a running cost of lines and filters and replacement fluid. It's complex. We need to teach our ICU nurses. And if you don't have a dedicated CRRT nurse, it's an increased workload for an already overloaded ICU nurse. Moreover, on the top of that, we have patients who need unexpected interruptions for multiple investigations. So, if possible, if we can go intermittent in these patients, it would have been much better. What is sustained low efficiency dialysis? So, by sustained low efficiency dialysis, we mean an intermittent form of dialysis which offers lower solute clearance maintained over a longer period of time. So it's not necessarily continuous, it's an intermittent for at least 6 hours. There are many names to sustain low efficiency dialysis like hybrid therapies, prolonged intermittent renal replacement therapy, extended daily dialysis. The beauty of sustained low efficiency dialysis is that what we do is we utilize the same intermittent hemodialysis machinery with some minor modifications and tweaks to the prescription. Now, if you look at the solute characteristics, if we compare sustained low efficiency dialysis with intermittent hemodialysis, both of them are diffusive strategies. So, if you look at the low molecular weight urea, you will see that both of them have comparable urea kinetics. However, if you compare it with a CVVH, which also removes medium to large size molecules, of course in CVVH you will be able to remove more medium to large size molecules. But the beauty of SLED is that we can do a SLED with a F. We can also add a convective component to SLED, and we can then utilize removing the medium sized molecules as well, as compared to just comparable to CVVH. So we can use SLED with F in some patients. Now SLED is cheap, and there have been multiple studies from even United States. This is a study from United States where they found, they compared CRRT heparin with CRRT citrate and SLED, and they found that SLED was almost 3 to 5 times less expensive as compared to CRRT. In my part of the world, SLED or SLED with convection costs around $100 per session. However, CRRT, the initiation cost in my center is around $500 plus ongoing cost of at least $200 every day. Now, SLED keeps the nurses happy as well. If you look at the CRRT nurses, ideally in CRRT, you need a dedicated nurse for CRRT, a dedicated nurse for ICU who take care of this child. On the other hand, in SLED, your ICU nurse does not need to be there for 24 hours taking care of the CRRT or a continuous renal replacement therapy in this child. So she does not need to take care of the emergency continuation, routine discontinuation of the circuit, hourly monitoring. So what we do is we do SLED in sick children every day in the morning, and by the time our shift is over around say 4 o'clock, we are done with our intermittent therapy. So we choose our patients who will be receiving daily SLED. So it keeps the nurses happy as well, because here we are doing an intermittent therapy as compared to a continuous renal replacement therapy. It's very common in my part of the world, and I can tell you this is data from adults in my center. And in the last many years, the adults undergoing SLED is increasing, and we only do CVVH or CVVH-DF in selected patients. So in fact, I can tell you in my part of the world, SLED is the most common modality in adults with AKI, and still we are trying to generate more data for pediatrics. It is evidence based, and I would like to share with you a meta analysis which looked at continuous renal replacement therapy with extended daily dialysis or a prolonged intermittent renal replacement therapy. Now, if you whether you look at the mortality with respect to the RCTs or observational studies, outcomes are the same. You can look at this forest plot, outcomes are the same. If you look at the kidney recovery, because continuous renal replacement therapy appears to be more physiological as compared to a intermittent renal replacement therapy. If you look at the kidney recovery, outcomes are the same. If you look at the fluid removal in RCTs and observational studies, again the outcomes are the same, whether you look at SLED versus CRRT. Similar data came from the Toronto AKI registry, where they compared SLED and CRRT, and they looked at the 30-day mortality, the 30-day RRT dependence, and early clinical deterioration. And they found that all of these parameters were same, whether you talk about SLED or CRRT. What about pediatrics? As pediatric nephrologists, now it is our duty to make and create more evidence in this field. Now, the first paper which came on sustained low efficiency dialysis with convection, it came from Taiwan way back in 2012. And the problem in this paper was that children less than 20 kg were excluded. And they looked at 14 children, and these 14 children, and if you look closely, out of these 14, 3 and 4 here, 7 were not on inotropes. So these were relatively stable patients who were put on SLED, and they could demonstrate that SLED was well tolerated. There was improvement in the metabolic parameters and the hemodynamic parameters in these patients. Now, in our country, we do SLED as a routine in sick children. If they're not on more than 2 inotropes, we will be offering them SLED as the first dialytic modality. So we were doing this since last many years. So initially we did a retrospective analysis of 3 centers from India, one from West Bengal, one from Maharashtra, and this is my center here in India. It was a retrospective analysis, and we found that over the last many years we had done SLED in 68 children, and you can see that they were relatively sick children. They were ventilated. Most of them were on ventilator. Most of them had MODS. They had septicemia. Almost half of them had septicemia. A quarter of them had fungal sepsis, and they had a relatively high PRISM score at the time of initiation of SLED. So they were sick patients. Now, what we do routinely in SLED is we give them a blood flow rate like CRRT around 3 to 5 ml per kg per minute, and we keep a dialysate flow rate not more than twice the blood flow rate. So we keep the dialysate flow rate not more than twice the blood flow rate. Now we found that we could go heparin free in almost 75% of these sessions. We did not use any anticoagulant in 75% of these sessions, and we could achieve the target ultrafiltration rate. Now, if you look at uh, what happened in these patients, we found that only 13% of them we needed to terminate the session because of hypertension or clotting of the circuit. There was an improvement in the blood pressure in these patients. The number of inotropes before and after were similar. There was improvement in the bicarbonate in these patients. However, we did find that these patients had post SLED hypophosphatemia in 3%, hypokalemia in a quarter, and after that, since whenever we do a prolonged dialysis in children, we keep a higher dialysate potassium. Otherwise, there's a risk of hypokalemia. There was improvement in the oxygenation index. They were sick patients, so yeah, almost half of them did die in this part of our study. Now we realized that we could go heparin free. So we started doing prospective study, and we looked at consecutive patients who underwent SLED with convection. So what we do is we give them a pre-filter replacement fluid in sustained low efficiency dialysis. So it's similar to hemodiafiltration in the ICU. So we could go consecutively in 70 children, 240 sessions as heparin free with pre-filter replacement. There were few patients who were around 8-9 kg also in this study, and we found that again we could show that heparin free SLED F could be tolerated. So the mean number of inotropes were similar before and after each session. There were improvement in the metabolic bicarbonate parameters, and there was the oxygenation index was similar pre and post. And when we looked at the SLED F complications, it was well tolerated. You can see that the premature session terminations were just 10%. Due to hypotension, around 9%. Only 1% of the sessions were because of the circuit clotting. They were now, we manage hypophosphatemia, hypokalemia well. So now we have very less incidence of post-SLED hypophosphatemia, post-SLED hypokalemia, and hypocalcemia. So in Melbourne in 2019, in the World Congress of Nephrology, our group, the PCRRT group with Dr. Bunchman, Dr. Rupesh, Dr. Mignon, we all were there, and we made the consensus guidelines for prescribing prolonged intermittent renal replacement therapy in children. And this was published in Hemodialysis International. This was published in Hemodialysis International a few years back, and I would like all of you to go through that journal. So what we actually do in these patients is, these are the machines which offer a SLED. They offer using a lower dialysate flow rate and a pre-filter replacement. What I do in my center is, most commonly I would be using a 5008 series by Fresenius. So what I do is, we use a pre-filter replacement. We use the HDF pre-dilution mode. We use the dialyzers, the high flux dialyzers, for using convection, mostly with a high ultrafiltration coefficient. So most of the times we would be going for these filters, FX40, 50 and 60, for children who are around 0.6, 1 to 1.4 meter square. And we go for hemodiafiltration, a slow hemodiafiltration. So suppose this child was say around 20 kg or 25 kg. We gave him a blood flow rate of around 3 to 5 ml per kg per minute, and the dialysate flow rate not more than twice of the blood flow rate. So this is the dialysate flow rate here, and we give them a continuous substitution rate of at least 25 ml per minute pre-filter. So as all of us are aware, pre-filter substitution rate, it gives them a convective dose as well, and secondly, it also prevents clotting of the circuit. We always use heparin free SLED F in our center. So if we are using a prolonged SLED more than 8 hours in a child, we use a lower bicarb, a higher potassium in the dialysate flow rate, so that these patients do not go into hypokalemia and do not get metabolic alkalosis in a prolonged dialysis session. So here it is, using a SLED F pre-dilution in these patients. So this is a typical prescription for the patient whom I showed you. We use a typical 5008S machine, which gives us the liberty to have lower dialysate flow rates. We use a high flux dialyzer, blood flow rate and dialysate flow rates as mentioned. We typically start, this is the minimum. So on a Fresenius machine which we use every day of our lives, this is the minimum substitution rate which we can offer. It does give them a convective dose. We go pre-filter. We keep the filtration fraction less than 25 to 30% to prevent the clotting of the circuit. We start with the ultrafiltration of 0, and as the patient tolerates, we increase the ultrafiltration rate. Heparin is always no in our sessions. We do not use heparin. Now the issues with sustained low efficiency dialysis is also the antibiotic dosing, because as all of us are aware that once your patient is on dialysis, there's a rapid elimination of the antibiotics. However, when this patient is off dialysis, there is a slow elimination. So we are trying to create more evidence in the field of pharmacokinetics in these children, because there's a need to have more understanding for dosing the antibiotics in these patients. Now, a talk on AKI and RRT cannot be complete without talking about COVID-19. And way back, 2 years back, our group gave a position statement on emergency preparedness with resource allocation, and we did recommend what Dr. Bunchman and Dr. Raina always says, that we need to do and offer a modality which you are good at. So if you are good in PD, you can offer PD in a COVID-19 patient. If you're good in SLED F, you can offer SLED F, or you can offer a short-term CKRT if you are running a very heavy ICU and you have a lot of patients to offer CKRT to. So we need to do and offer what we are good at. Now coming to, once the patient improves and his AKI improves and there is a time for discontinuation of RRT. Now when do we discontinue RRT? Of course there are many parameters including improvement in the urine output. Once a patient is able to manage his obligatory fluid requirements, and you can stop dialysis in those patients once the acute event has resolved. Now what we do is we use PIRRT or SLED also as a step down therapy. So once a patient is on CRRT, he's improving, his number of inotropes are reducing, his urine output is improving, we step down to PIRRT, and then if he's improving, we go on to the typical intermittent hemodialysis. So we do believe that SLED is a very good modality even as a step down therapy for patients when their AKI is recovering. It does help them in improving the hemodynamics, managing the fluids in these patients, and facilitating renal recovery. We are in process of publishing data on our step down as well. So coming to what choice of modality we offer in our part of the world, of course for neonates who infants, we use PD first. But if there's a life-threatening hyperkalemia with a patient who has toxins, tumor lysis, we offer hemodialysis. However, for a hemodynamically unstable patient who is fluid overloaded, septicemia, multiple inotropes, another modality which we use in addition to CRRT is SLED, which is now a routine modality in our part of the world. So to conclude, CKRT or intermittent KRT in AKI in the developing world is evolving. There's lot to learn and implement, and there's a need to develop more data in this part of the world, especially in SLED. We need and we do train manpower every year. We used to do a training course in India, and in COVID-19 we switched to the online mode, and I hope that we'll be able to do all the training of the manpower for the South Asia uh, face to face once COVID-19 reduces. So PD or SLED, they can be life saving when required. So it's not just about CRRT. I think we need to do what we are good at, and any modality. There is no data showing SLED or hemodialysis or one modality is better than the other. So we can use modality as per your institutional expertise. I would like to take this opportunity to invite all of you to our virtual meeting this time in June, which is on point of care ultrasound. So the PCRRT group, the iconic group, we are planning this point of care ultrasound course in pediatric nephrology. So please go to the piconephrologycourses.com to register. We are planning more focused courses in future as well. And as the PCRRT iconic group members, I would like to invite all of you to join us to help create more awareness about critical care pediatric nephrology all over the world. This is our practical handbook, which has all the guidelines, all the prescriptions, which I just now talked about, whether it was peritoneal dialysis, hemodialysis, CRRT, and so on. And I'll again thank the organizers for inviting me here. Thank you. And I'm open to all the questions. Thank you.